you'll see the highest quality evidence of TRT safety. Learn how to spot true risk versus hype and walk away with practical guidelines you can trust. If you're a clinician, patient, or just curious about men's hormone, this is for you. Here's the setup. As men age, testosterone drops, slowly at first, then faster after 40 or 50. This decline often travels with obesity, diabetes, and metabolic syndrome, all known heart disease accelerators. But here's the twist. Is low testosterone causing the heart problems, or is just a red flag that your health is already slipping? That's the mystery we'll solve. Big population studies paint a concerning picture at first glance. In one massive analysis of over 255,000 participant years, men with very low testosterone had higher all-cause and cardiovascular mortality. The huge UK Biobank study followed over 210,000 men for 9 years. Lower testosterone linked to dying earlier, but surprisingly not to new heart attacks, strokes, or cardiovascular death once they adjusted for other factors. A Danish study using clever statistical weighting, the cardiovascular link almost disappeared. Only overall mortality stay elevated. Suspense is building. Is low T guilty or just guilty by association? Meta-analysis of 10,000 of men confirmed the pattern. Low endogenous testosterone predicts high cardiovascular death and events. But watch this, the signal is much stronger in men over 70. In younger men, almost no association. This age difference is a huge clue. Now, for the plot twist, scientists use genetic variants as a natural randomized trial. Lifelong high or low testosterone exposure without the usual confounders. The results shocked many. Genetically higher testosterone was linked to more thromboembolism, heart failure, myocardial infarction, and even higher coronary artery disease risk, partly through raised blood pressure. So, observational data say low testosterone is dangerous, but genetics suggest higher T might not be innocent either. Who is right? Observational versus genetic data. Here's the resolution. The apparent protective effect of higher testosterone in everyday study is slightly confounded by poor health, lowering T levels. Low T is more often a biomarker of illness than the direct villain. The Endocrine Society agrees it's a marker, not necessarily the cause. Causality is hard to prove from observation alone. Bottom line from the experts, treat low testosterone carefully with clear symptoms and confirmed labs. Always individualize the risk-benefit discussion. Time for the main event. The central question every man on or considering TRT wants answer. Does replacing testosterone at normal doses raises heart risk? The answer from the best evidence will surprise you. Transverse trial, landmark evidence. Enter Transverse trial, the definite largest randomized placebo-controlled study ever done on this topic. Over 5,200 men aged 45 to 80 with real hypogonadism, half over 65, more than half already had heart disease or high risk. They used real physiological doses. What happened to major adverse cardiovascular events? We'll reveal this result next. No increase in major adverse cardiovascular events with testosterone versus placebo. The curve overlapped perfectly for cardiovascular death, heart attack, and stroke. Safety held up across older men and those with diabetes, obesity, or existing heart disease. This was a watershed moment. Supporting meta-analysis on testosterone replacement therapy, TRT. Multiple meta-analyses back it up. No rise in heart attacks, stroke, or cardiovascular death. The Androgen Society of 2024 position paper was crystal clear. It has now been conclusively determined that properly use of TRT does not increase risk of heart attack, stroke, or cardiovascular death. A specific risk, thromboembolic and arrhythmic event, but it's not entirely risk-free. In transverse pulmonary embolism was higher, 0.9 versus 0.5. Atrial fibrillation was also more common, 3.5 versus 2.4. A large real-world study confirmed modest increase in atrial fibrillation and blood clots. This risk appears highest in the first few months. Knowledge is power. We can manage this. Mechanisms contributing to thromboembolic risk. Testosterone ramp up red blood cells production, which can lead to thicker blood and higher clot risk if not monitored. It also influences coagulation pathways. See the detailed pathway diagram, the New England Journal of Medicine, displaying exactly how this happens at the cellular level. Additional prothrombotic mechanisms. Testosterone affects platelets, thrombin, fibrinolysis, and endothelial function. The key clinical takeaway: monitor hematocrit religiously. Stop or adjust it if it climbs too high. Age and comorbidity consideration. Younger men with classic organic hypogonadism, like Klinefelter syndrome, have decades of safe experience with TRT and lower baseline risk. In older men, Traverse proved safety even with common comorbidities like diabetes and established heart disease. Comorbidities themselves didn't make TRT riskier. High-risk patient subgroups. Caution is needed for men with prior blood clots or thrombophilia. Consider protective measurements. Avoid starting right after a recent heart attack or stroke, or in severe heart failure. In obese men with only mildly low T, benefits may be smaller. Importance of TRT formulation. Formulation matters a lot. Transdermal gel, the one used in Traverse study, has the best safety data and allow easily adjustment. Injectable show higher cardiovascular events and hospitalization compared to gel in large studies. Oral alkylated forms, avoid them, significantly higher risk. Newer oral and supraphysiological dosing. Newer oral undecanoate still needs more long-term data and can raise blood pressure. And never confuse physiological replacement with bodybuilder level supraphysiological doses. Those cause remodeling, terrible lipids, hypertension, and real damage. Stay in the safe mid-normal range, 450 to 600 nanomillis per deciliter. Guidelines are unanimous. TRT only for men with clear symptoms plus 2 confirmed morning low testosterone level, usually below 300. The lower and more consistent the level, the greater the potential benefits. Treatment goals and dosing. Goal: restore to the middle of the normal range, 450 to 600. For most older men, start with short-acting gel at 4.5 milligrams daily and titrate carefully. Monitor protocols. Monitor at 3 to 6 months, then yearly symptoms, testosterone level, hematocrit stop if over 54. PSA, blood pressure, and watch for clot or arrhythmia signs. Baseline assessment is non-negotiable. Absolute contraindication to testosterone replacement therapy. Never used in active prostate or breast cancer. If fertility is desired soon, baseline hematocrit above 50%, recent major cardiac event, severe heart failure, or untreated severe sleep apnea. Clinical outcome summary. Quick visual summary. MACE, heart attack, stroke, and death, no increase. Atrial fibrillation and pulmonary embolism, modest increase that needs attention. Long-term data beyond 5 years is still maturing. A structured clinical approach. Practical steps. Confirm the diagnosis properly. Assess heart and clot risk upfront. Prefer gel. Titrate thoughtfully. Monitor closely. Always share the decision with the patient under supervision of urologists and a cardiologist. Key takeaways. Final takeaways. Low testosterone is often a warning light for poor health. Physiological TRT, when done right, does not increase major heart events. This is now conclusively shown in studies. A small risk of atrial fibrillation and clot exists and must be managed. Choose the right formulation and monitor like a pro. Always choose the right patient. Remaining uncertainty. We still need longer-term studies beyond 5 years and more data in certain groups. Individualized care remains key. All data here comes from landmark trials like Traverse, major meta-analysis, and position statement from the Endocrine and Androgen Society. Full reference are in the description and on the slides. That's the latest, most balanced evidence on testosterone cardiovascular risk. If this video helped clarify a confusing topic, drop a like, leave a comment with your biggest takeaway or question, and subscribe to Cardiology 5 for more trusted, no hype medical education. Hit the notification bell so you never miss an update. Thanks for watching, stay healthy, and we'll see you in the next one. This is, remember, only for educational purpose. Thank you so much.